Welcome to Genomics Now, a podcast series where you can learn how genomics is developing in England's NHS. This podcast series is recorded in 2024 and is part of the North Thames Genomic Medicine Services Educational Toolkit. In each bite-sized episode, we explore what is changing in genomics. We answer the questions on genomics we've been asked by the different healthcare professionals. We talk about the ways genomics may impact different healthcare roles and how genomics can be used to successfully improve patient care. Hello, I am Dr. Shazia Mohammed, and I'm part of the North Thames Genomic Medicine Services Workforce Education and Training team. And in today's episode, I hand over the mic to Darmisha Chauhan.
Podcast was hosted by me, Darmisha Chauhan, and I sit in the North Thames Genomic Medicine Service team, which is hosted by Great Ormond Street Hospital. And I work as the lead pharmacist within the team. And today my guest is Nick Bass.
Hi, I'm Nick. I'm an academic psychiatrist based in the Molecular Psychiatry Lab, which is part of the Division of Psychiatry at University College London. Our research team studies genetic effects on the development of mental illnesses such as schizophrenia and bipolar disorder. In my clinical role, I specialise in the assessment and treatment of people with dementia, working with the Tower Hamlets Memory Clinic in East London. I joined the North Thames GMSA team a couple of years ago now, and it's been great to start thinking about how genomic testing could be used in mental health services to improve care.
Nick, thank you for joining. So for this episode, we'll focus on implementation of pharmacogenetic testing into NHS services. In episode 1, we described that we had 4 genes which were routinely tested within the NHS setting. And for episode 2, we went through a few pharmacogenetic terminologies. So if there are any terms and concepts we don't explain through today, please do listen back over the series, as we have given lots of helpful explanations within this episode. So let's get into this session on implementing pharmacogenetic testing into the NHS. So let's imagine that we're implementing a new pharmacogenetic test from the National Test Directory, and we will use CYP2C19 as an example. 19 is a member of the cytochrome P450 enzyme family, and it's encoded by the gene CYP2C19. And on pharmacogenetic reports, the gene will always be described in italic. So CYP2C19 is involved in the metabolism of drugs we routinely prescribe, such as clopidogrel, voriconazole, proton pump inhibitors, and antidepressants such as serotonin reuptake inhibitors and tricyclic antidepressants to help support prescribing decisions. Within cancer settings, genetic testing and pharmacogenetic testing is well established. I understand, Nick, that this is not necessarily the case for mental health, and in fact, there may be more challenges when it comes to pharmacogenetic testing.
Yes, Darmisha, I think it's fair to say that on the whole, clinicians working in mental health services are far less familiar with the use of genetic testing. However, we have found that there's been a lot of interest in pharmacogenetics, both from clinicians and, most importantly, service users. Talking very generally, there are now a large number of effective medications for mental health conditions. However, the medications are certainly not effective for everyone, and many have significant side effects. The big problem is knowing which medication to recommend at the outset. Unfortunately, finding the best medication for an individual is largely a matter of trial and error. Taking antidepressants as an example, approximately 2/3 of people don't respond to the first antidepressant they're prescribed. Given that it can take months to determine whether an antidepressant is effective, there seems to be huge potential to improve treatment if outcomes could be more precisely predicted. We received feedback from service users that there's a lot of enthusiasm for genomic testing and to help better personalised treatment.
Well, it's great to hear that there is enthusiasm to use pharmacogenetic testing where it's clinically appropriate. So, Nick, if you were involved in supporting the implementation of pharmacogenetic testing at your local trust, what would you want to consider first? Say, for example, the gene in question was CYP2C19 for antidepressant.
If CYP testing was added to the directory, I think the first consideration would be to figure out how testing could be embedded into the clinical pathways that exist already. The structure and delivery of mental health services is complicated, and many of the services are community-based rather than hospital-based. To be honest, planning probably needs to start at the level of the integrated care board and proceed down through individual trusts and then on to individual services. Obviously, involvement of key stakeholders is needed to develop testing pathways. To my mind, the key stakeholders would include patients, clinical directors, pharmacists, and the relevant genetic laboratory hub, and also, of course, primary care.
So you mentioned the genomic laboratory hub. So from the mental health service side, would there be any crucial testing requirements? So, for example, testing turnaround times?
Yes, this is a very important point. I can imagine testing being conducted under a variety of circumstances, but I think there are situations where you could need the result back very quickly, and then others, of course, not so quickly.
So could you give us some examples?
Yeah, for sure. Just as in general hospitals, most appointments in mental health services are routine, but sometimes people need to be seen urgently, and sometimes very urgently indeed. So let's imagine someone who presents in crisis with first episode psychosis but has not previously been prescribed an antipsychotic. They're detained under the Mental Health Act and admitted to an inpatient unit. They're experiencing delusions, hallucinations, they're very agitated and distressed. Urgent treatment with an antipsychotic is indicated. In this scenario, SIP testing could be very useful to guide the choice of initial antipsychotic. Potentially, this could accelerate the identification of an effective antipsychotic, reduce high-dose prescribing, and avoid unpleasant side effects. In this scenario, testing would be urgent and needed within 24 to 48 hours to be useful. However, saying that, in most situations, such a rapid turnaround would not be needed. For example, a routine referral from primary care for someone with moderate depression. Let's say they had a course of CBT and one SSRI, but have not improved noticeably over the last 18 months. In this situation, SIP status could potentially be used to inform the choice of the next antidepressant to trial. However, while not wanting to delay treatment too much, waiting up to 4 weeks for a test result would seem entirely reasonable.
So you've mentioned SIP testing to help guide the choice of antipsychotic medications. And in episode 3, we heard about the pharmacogenetic clinical trials which are underway, and hopefully there will be data to support the routine use of antipsychotic medications, as you've illustrated how useful this could be within the patient pathway. But it's interesting, as you mentioned, pharmacogenetics could reduce high-dose prescribing and side effects. Do you think or feel that this will lead to greater patient adherence to medication, or even lead patients to have more positive engagements with mental health care services?
Yes, I'm very hopeful that would be the case, particularly for antipsychotics. I don't think we should underestimate the impact of side effects and a lack of clear efficacy for the patient on adherence. Disengagement from mental health services is common among people living with schizophrenia, and anything that can be done to make treatment a more positive experience would be absolutely great.
So, upon consenting, once we've implemented the pathway, I think that's an important process of it. So do you see any barriers or challenges to the consenting process within mental health service? So, for example, in cancer genetic testing, it's very much routine, and with pharmacogenetic testing, cancer patients view this as another safety test, and in many cases, only a verbal consent is obtained. Do you think this would be different in mental health care?
In general, no. In fact, I think it's important that it's considered routine in mental health settings, and people with mental illnesses are not seen as special cases. Most of the time, mental illness will not affect a person's ability to consent to testing. There will, of course, be circumstances where people may not have the capacity to consent. Perhaps the person that I talked about in the hypothetical scenario with psychosis above. However, most mental health professionals are very familiar with the process of seeking advice from consultees and best interest decision-making in accordance with the Mental Capacity Act.
It's good to know how the Mental Capacity Act can help guide with pharmacogenetics. So now that we've thought about the consenting process, who do you think should be able to order a pharmacogenetic test?
Well, definitely psychiatrists and pharmacists, but non-medical prescribers are quite common within mental health services, so also some of them. I think it needs to be remembered that as a rule, mental health services are provided by multidisciplinary teams. A person's first contact with mental health service may not be with a medic. For example, in our memory clinic, the initial assessments are usually carried out by the clinic nurses. So therefore, I think it's very important that the whole MDT is at least aware that variation in our DNA can have effect on medication, and be aware of any relevant pharmacogenetic tests in the National Test Directory.
So how do you think we need to increase our knowledge and confidence in pharmacogenetics?
Podcasts, obviously. Lots of them. No, in seriousness, I think the Genomics education program resources are really great. It seems to be more a matter of encouraging people to engage with these resources. I think trusts individually need to recognise that genomic medicine is a thing and it's happening and there's no going back, and have a strategy to incorporate genomic testing, genomic education into trust-based education and training. While all HPCs need to be aware of genomics, education training, of course, needs to be tailored according to their specific roles and services.
So you talked a little bit about pharmacogenetic education for healthcare professionals, so it's good to know your kind of view on it and the strategy that is needed, particularly the different way that we need to tailor the education training for different healthcare professionals. And in episode 5, we will be discussing more on pharmacogenetics and patient conversations. But Nick, in your clinical area, are there any challenges that may occur or you've faced within your own clinical practice when it comes to patient or carer education, and how did you overcome this?
Yes, I mean, in the memory clinic, discussion of genetic causes of dementia and diagnostic testing can certainly be a challenge. There are often many intersecting factors that contribute to that challenge. For example, level of formal education, different explanatory health models, first language, and other factors. I think the most important way of meeting that challenge is giving people enough time to absorb the information and consider options. Often we carry out discussion over the course of a number of appointments, and this is supplemented by written materials that people can take away and read and have a think about with their family before the next appointment. Obviously, for any new pharmacogenetic tests that come online, we'll need new patient information sheets and have those translated into different languages. Also, I think that information videos and animations could be a very useful tool to aid these discussions. I mean, personally, I think genetics is quite visual.
So thank you, Nick. I've really enjoyed this episode and how we have learned how we can implement pharmacogenetic testing into mental health care pathways, and it's reassuring to hear that it's not too dissimilar to other clinical pathways, such as what we've seen in cancer pharmacogenetics.
And thank you too. It's been really good to be able to talk about pharmacogenomics in the mental health settings and sort of raise the flag for mental health services. So thank you.
Thank you for listening to this episode of Genomics Now, a series of conversations hosted by healthcare professionals. The North Thames Genomic Medicine Service aims to complement other genomic-focused educational tools with these bite-sized podcasts. So do visit our website for more resources and updates on genomic-based clinical developments and research. If you've enjoyed this episode, don't forget to share your thoughts and spread the word by tagging the North Thames Genomic Medicine Service on social media.